certainly, again, and I think it's the most recent sort of revolution in the science that has translated into a real benefit for many, many patients. It's very exciting. And it's an exciting time, and we haven't seen the end of it. So the fact is, we're still at the tip of the iceberg in terms of its ultimate sort of power and capability. I'm really excited about where things are going. But just to step back and talk about it for a second, it does involve the immune system of the body, and we know that the patient's immune system is an asset for doctors, for scientists, for the patient to battle their cancer. The problem is that the immune system often doesn't see the cancer because the cancer came from self. The immune system is largely there to repel and defend against invaders, foreign. You've got a virus, you've got a bacteria. It's really good about attacking those. Cancer, not so much. Now, it's not identical to self because remember, those alterations have occurred. And so, it's not like any other cell in the body, and yet it's still being sort of tricked by the immune system not to being attacked. And so what we're trying to do is to figure out how that works and where we can interrupt it. And the one really great example is in this molecule called a checkpoint inhibitor, called a PD-1 inhibitor or antagonist, where basically there is a system that was discovered about 5 or 10 years ago now, where the cancer was producing a protein on its surface that was basically cloaking it from and hiding it from the immune system. So that immune system was surveilling, it would see this protein and say, oh, nothing here, nothing going on here, right? What they learned is if they interrupted that signaling and they blocked that protein with something called anti-PD-1, there's about 8 or so drugs out there now that attack it, things like pembrolizumab, nivolumab. You may have heard of Keytruda or Opdivo. Those are the trade names for those. But this class of drug then interrupt that interaction. Now, all of a sudden, the immune system can start to see that tumor. Sometimes it's not enough. Sometimes it is. But where it impacted patients amazingly well was in melanoma, where before this sort of interaction and protein was discovered, most of those patients, again, who were in late stage or advanced stage were unfortunately succumbing, were dying from their cancer at some point from the cancer itself. So it was life-limiting for them. We are now curing about 50%, about half of all of those patients. And again, what we're talking about is, tens of thousands of patients a year globally. And that's just, an amazing achievement. Now, I'm not satisfied with 50%. I want 100%. And so again, how can we go beyond that? And we're trying now combinations. Scientists are discovering how to combine that therapy with other therapies, whether it be chemotherapy or whether it be others. And, we're learning in lung cancer that is become part of the standard for some patients is to have that immunotherapy. But we try extending it even beyond. So you don't necessarily only have to have metastatic disease. Maybe earlier stage can now get that immunotherapy. The immunotherapy is not without risk. About 10% of patients have severe side effects, but they're treatable and reversible. 90% of patients don't have severe side effects. And yet 50% of melanoma patients are being cured from it, compared to almost zero. So the upside is on the benefit. And so we look at the risk and the benefit, and we help the patient to assess these for themselves and make that determination of what am I willing to try here to try to do better. But the better can be actually much better sometimes. And that's what's really exciting.
How is immunotherapy delivered to the patient? Is it a pill? Is it intravenously?
Yeah, it can be all sorts of things. I'd say, newer medicines tend to be more intravenous. And so, and these are fancier medicines, which include antibodies or other, there's something called CAR T-cell therapy, which is an exciting therapy where they take out your blood cells and they put it in the lab and they teach these cells to attack the cancer, and then they give them back to the patient. So those are all intravenous. There are some oral therapies still. And again, we can go and select for patients who need one or the other, or prefer one or the other. Obviously, everyone does prefer oral, but the intravenous can be not so bad, especially if it's every month or so. It can be quite tolerable. So more important to me is what side effects these cause.
Yeah.
But you find a variety of both intravenous and oral, more on the intravenous side, I'd say.
Got you. So we did have a question from someone about immunotherapy that kind of goes a little deeper, where that they've been taking an immunotherapy, and they've been told by their oncologist they're going to need to stop taking it next year. And their kind of worry was, it felt like they were giving up, or they felt it wasn't going to stop working, or like. So, how does immunotherapy work? Is it something you take it forever? Is it maintenance? Is it like and sometimes is it curative? Is it courses of it?
Yeah, it's a great question. And again, a lot of it is that we're still learning about these therapies and how they work. Again, the thought is that we're teaching the immune system to do something different. And once it learns that, we don't necessarily have to keep teaching it. It's been taught. And so in that sense, most immunotherapies have been written to stop at 2 years because frankly, they just haven't seen benefit for giving immunotherapy beyond 2 years. But again, I just mentioned that, immunotherapy hasn't been around for more than 5 or 10 years. So it's still relatively short time. We're still learning. I wouldn't be surprised that if tomorrow we found out that someone got it for 3 years and did better, or one group of cancer patients or something like this. So again, I'd say the jury's not out yet. There's another reason to stop therapy, and that's when if they see the cancer growing, they decide it's not working. But that's not the sort of thing you would project a year in advance. And so this sounded very much like, the fact that most of the companies said, well, after 2 years, we're just going to stop because we just don't see evidence to say it's helpful to the benefit would have been delivered already in the 2 years, and therefore not helpful to go beyond that. But again, it's still early days in terms of that decision.